The effects of the contract-relax-antagonist-contract form of proprioceptive neuromuscular facilitation stretching on postural stability. Department of Physical Therapy, College of Nursing and Health Sciences, Florida International University, Miami, Florida. Let's skip the abstract. Introduction. Stretching before participating in athletics is common practice and at all levels of sports and fitness. Clinicians and strength coaches traditionally recommend stretching in an effort to reduce injury and improve performance. Even though this is a common practice, there is little scientific evidence to support the use of preactivity stretching as a means of reducing injury and improving performance. A thorough investigation into all aspects of this practice is important to help identify best practices and to add to the body of knowledge. A number of studies suggest that acute and prolonged stretching impairs performance by decreasing force power. The decrease in force and power have been attributed to neuromuscular impairments in the musculotendinous unit, resulting in decreased muscular tendinous stiffness, i.e., increased slack, and occur with different types of stretching. Musculotendinous stiffness refers to a relative resistance provided by muscles and connective tissue to stretch, and this is known to influence the efficacy of internal forces generated by the muscle by providing a more effective means of force transmission. Musculotendinous stiffness refers to the relative resistance provided by muscles and connective tissue to stretch, and this is known to influence the efficacy of internal forces generated by the muscle by providing a more effective means of force transmission. Changes observed in the musculotendinous unit may also affect the other structures within muscles and tendons, including proprioceptive receptors, muscle spindles, and Golgi tendon organs, GTOs, by increasing laxity, reducing force output, and consequently resulting in negative effects on performance tasks requiring proprioception. Postural stability is a complex process that depends on both visual and proprioceptive input to maintain equilibrium, balance, and keeps the body upright. Accordingly, the terms balance and postural stability may have been interchangeably. Balance requires tension produced by muscle activity and involves the communication of automatic, postural, and voluntary motor commands on both the trunk and limbs. Most studies that examine the effects of stretching on performance measures have been limited to its effect on power, maximum strength output, force development, and comparison of various stretching approaches. Only one group of researchers examined its effect on balance. Behm et al. Investigated the effects of force, balance, movement, and reaction time after an acute bout of static stretching. Acute static stretching produces a decrease in balance, reaction time, force, and movement time. Additionally, other investigators have identified a possible link between poor balance, functional ankle instability, and risk of injury because of altered reflex sensitivity, proprioceptum. These findings have important clinical significance because lower leg proprioceptum is important in triggering automatic postural responses during many functional activities. However, these findings cannot be generalized to other forms of stretching. One common form of stretching is proprioceptive neuromuscular facilitation, PNF stretching. Proprioceptive neuromuscular facilitation methods involve isometric contractions with either active or passive static stretching. This method uses stimulation of proprioceptors to induce changes in the muscle fibers and increase range of motion, ROM, through autogenic inhibition, stimulation of the agonist, and reciprocal inhibition, stimulation of the antagonist. Contracts, relax, antagonists, contract, CRAC, is a form of PNF stretching that involves an initial contraction of the agonist followed by an active or passive contraction of the antagonist or increase ROM, range of motion, and it is thought to be most superior at increasing ROM. The increased ROM seen at the CRAC PNF stretching also produces a concomitant depressed Hoffman reflex, H reflex. The H reflex is a clinical measure of motor neuron excitability induced by stimulation of sensory fibers, with the resulting afferent discharge causing an excitatory potential in the motor neuron pool after a synaptic delay. The decreased motor neuron excitability may potentially increase tendon slack and negatively affect force transmission among muscle fibers. However, other investigators have demonstrated increased electromyographic EMG activity with antagonist contract relax ACR, which is similar to CRAC, with the only difference being that no initial contraction of the agonist. The investigators argue that the increased EMG activity may help offset the tendon slack associated with acute static stretching. Based on this evidence, the concurrent investigators hypothesized that an increased muscle activity may lend itself to more favorable firing, which may positively affect tension development, reduce tendon slack, and result in improvement or maintenance of balance scores. A warm-up consisting of low-intensity aerobic activities such as a 10-minute jog is often combined with pre-activity stretching and is believed to offset the mechanical changes produced by stretching by increasing EMG activity and positively influence force development. Rosenbaum and Henning concluded that it is not advisable to use only static stretching before exercise and suggested that the static stretching may be followed by a general warm-up, such as a 10-minute run to improve force development. Given the available evidence that certain forms of PNF stretching enhances EMG activity, the various physiological effects that occur with the various forms of PNF techniques, the effect of warm-up on the pre-stretched muscles, and the paucity of data related to the stretching and balance, research related to the effects of various types of stretching on performance components is warranted. Therefore, the purpose of this study was to examine the effects of CRAC form of PNF stretching on postural stability as measured by balance scores with and without warm-up. Methods. Experimental approach to the problem. There is evidence that suggests PNF stretching increases range of motion, ROM. There is also evidence that suggests warm-up and static stretching increases WOM. Because of the limited availability of scientific evidence related to various forms of PNF stretching on performance measures such as postural stability, the purpose of the study was to examine the effects of the CRAC form of PNF stretching on postural stability, with and without warm-up. The research design was a repeated measure design. One independent variable was crack PNF stretching with 3 different conditions. The 3 conditions were warm-up followed by CRAC, crack PNF stretching condition, warm-up and stretch, WS, CRAC, crack PNF stretching only, SO, condition, and no stretching, CON. The second independent variable was time, with 2 level, pre and post stretching. The dependent variable assessing postural stability were the overall stability index, OSI, anterior and posterior, AP, stability index, APSI, as well as the medial and lateral ML stability index. Subjects. 30 healthy individuals, 15 men and 15 women volunteered to take part in the study. Ages 25.17 plus or minus 5.4 years. Height 173.76 plus or minus 8.2 centimeters. Weight 72.03 plus or minus 14.87 kilograms. The number of men and women in the study were the same in each group to account for ROM gender differences at the hip. Participants were recruited from the Florida International University and local fitness clubs. All participants were in good health, operationally defined as asymptomatic without signs and symptoms suggesting of possible cardiopulmonary or metabolic disease, and no history of head or musculoskeletal injury involving the lower limbs within the last 6 months. All participants were involved in a regular fitness program consisting of at least 3 hours a week of moderate to intense cardiovascular exercise, 70-90% maximum heart rate reserve, MHRR, and completed a health history questionnaire before the study. Participants were informed of the experimental risks and signed an informed consent document before the investigation. The study was approved by the Florida International University's Review Board. Balance was measured via the Biodex Balance System. Biodex Medical Systems Incorporated, Shirley, New York, USA. The testing protocol included a familiarization session of 2 practice trials designed to reduce a learning effect. A unilateral stance was used to recognize the patient's center of gravity over a small base of support and to better mimic the participation of athletics because running and other athletic activities rarely require both feet planted on the plane surface. Talantola et al. Argued that repetition of a task results in a learning effect. They suggested that improvement of a task performance occurs because of a learning effect. However, investigators found no significant differences in dominant limb stability tests between any of the 6 trials using the Biodex balance system. They also demonstrated that the Biodex balance system can produce reliability measures as indicated by R equals 0.94 for OSI, R equals 0.95 for anterior posterior stability index, APSI, and R 0.93 for MLSI. Based on findings in this study, they recommended 2 practice trials followed by test trials. During the current study, participants were asked to use the handrails only if necessary to keep from falling. The primary investigator inputted all the data for the Biodex computer. Data included body mass in kilograms and foot positioning on the platform grid. Biodex balance systems provided prompts for the investigator and participant. Each trial consisted of a 30-second testing session and the collection of data. At time of 1 minute was used to obtain all data from the computer and for the next trial to begin. The platform was set at level 2, which allows for the most movement, thereby requiring the participant to provide optimal postural control and stability. 5 trials were compiled for each testing session. 5 30-second trials were used to collect mean measures of OSI, APSI, MLSI, present time in zone, and percent time in quadrants. Body mass was measured using a digital medical platform scale model BWB 800S, Tineta Incorporated, Brooklyn, New York, USA. The digital medical platform scale has a body mass capacity of 200 kilograms with an accuracy to the nearest 0.1 kilogram. The scale was calibrated before each data collection session. Participants were screened for cardiovascular risk factors by measuring blood pressure using a standard sphygmomanometer, resting heart rate using digital palpation of the radial pulse, and health history questionnaire. Goniometric measurements using a standard goniometer were performed for the initial end ROM of the ankle joint, and a gravity-assisted protractor was used to measure the hamstrings and iliopsoas muscles groups. A certified athletic trainer acted as an assistant and recorded the measurements from the gravity-assisted protractor. Pilot testing was performed before the study, N equals 10, number of trials, 2, intra-tester reliability of the ankle joint goniometer measurement was high, R equals 0.95. The PNF CRAC method was chosen because of the paucity of data related to this form of stretching on balance and the differing physiological effects produced by method. The CRAC PNF stretching technique used in the WS protocol was consistent with principles described by Knott and Voss. Each stretch consisted of a passive initial stretch to the point of mild tension or restriction, followed by a 7-second isometric contraction of the target muscle. The subject was then instructed to contract the opposite muscle group for an additional 4 seconds using a concentric contraction, which provided a new starting point. After the 4 seconds, the procedure was repeated. The primary investigator performed the protocol on the participant 4 times for the hamstring as well for the iliopsoas and quadriceps muscle groups and 3 times for the plantar flexors. The fewer number of times chosen for the plantar flexor was because of the small ROM available at the joint, 20 degrees, and the time required to move to another muscle group was 10 seconds. A certified athletic trainer was used as an assistant during the study and provided the data recording during the CRAC PNF protocol. A pre-recorded tape was included to ensure consistency of the CRAC PNF protocol. Once the lead investigator was in place for the first stretching maneuver, the assistant pressed the play button for the tape to begin. The tape provided prompts for the lead investigator, allowing for consistency of contraction and active movement times during CRAC PNF, and the time taken to move to another muscle group. For the WS group, after initial balance assessment, this group then performed 6 minutes of jogging on a treadmill at 65% of MHRR. The MHRR was calculated using the Carbonin formula, and a heart rate monitor device was used to monitor intensity during jogging. After completion of jogging, within 2 minutes, the participant was taken through the PNF CRAC protocol. For the SO group, after pre-stretch balance assessment, participants were taken through the CRAC PNF stretching experimental protocol. For the CON group, the participants were asked to read an unrelated article between the pre- and post-balance assessment. The duration of the interval between the pre- and post-test was equivalent to the interval between pre and post tests for the WS experimental group. A rest time of 12 minutes was established during pilot testing and used in this procedure. During all stretching conditions, standard position and instructions were given, which was dictated by the muscle being stretched. All stretches were performed on a padded plinth for the quadriceps and iliopsoas muscle groups. The participant was in the prone position with his or her knee flexed at approximately 70 degrees. The investigators placed one hand on top of the participant's sacrum and the other hand under the distal thigh and knee cap. During the stretch, the participant was instructed to press and involve the thigh and hip towards the investigator's hand. Instructions were also provided to avoid lifting the opposite hip off the plinth. For the hamstring muscle group, the participant was supine on the plinth and an initial passive stretch of the hamstring was performed. Once an end point was established, the ankle was placed over the investigator's shoulder. The participant was instructed to keep the hips on the plinth, while the investigator kept the knee extended by pressing downward just above the patella. The investigator applied force by pushing with his shoulders while trying to step forward. For the triceps surae, the participant was in the supine position with knees extended and ankles relaxed off the plinth. The investigator placed one hand on the participant's knee while the other hand was on the heel with the forearm resting on the ball of the foot. The passive stretch and force of the investigator was applied by moving the ankle into dorsiflexion. A familiarization session was conducted at the Florida International University Sports Science Research Laboratory 24 hours before the study. Balance assessment was practiced on 3 separate repetitions to reduce the learning effect of balance testing. 3 practice sessions have been established as the frequency necessary to minimize the learning effect. Participants were instructed to return to the laboratory on the following day at 8 a.m. having consumed a light breakfast wearing athletic clothes that allow for a full range of motion. Athletic supporter, sports bra, mesh shorts, or cotton tights, cotton t-shirts, sweat socks, and running shoes. Initial balance measures were recorded for all groups, and a time of 2 minutes was taken between completion of the pre-stretch balance assessment and commencement of the assigned procedure. Range of motion measurements during the stretching protocol were recorded for initial and final stretched positions. A gravity-assisted protractor, Empire Level Manufacturing Co., Mukwonago, Wisconsin, USA, and a geniometer, Roland Medical Products, Fenimore Falls, Wisconsin, USA, were used. Geniometric measurements were performed by the lead investigator, dorsiflexion only, and the data collected of the gravity-assisted protractor was done by an assistant. Preceding measurements with the gravity-assisted protractor, the device was calibrated. Preceding measurement with the goniometer, reliability measures were performed, and an R equals 0.95 was established. The gravity-assisted protractor was placed on the distal femur. The goniometer measurements, the fulcrum was centered over the lateral malleolus, the stationary arm was aligned with the long axis of the fibula, and the movement arm was parallel to the long axis of the fifth metatarsal. The anatomical landmarks for goniometric measurements have an identification mark to ensure consistency of placement. Specific rest durations were applied to the 3 conditions before post-stretch balance assessment. For the WS group, this was a time of 3 minutes after completing the stretching protocol. For the SO condition, this was a time of 2 minutes after completing the stretching protocol. For the CON condition, this was a rest time of 12 minutes from the pre-stretch assessment. The rest times were employed to help reduce the effects of fatigue. The WS condition was given a 1 minute extra total time of 3 minutes because this condition required the performance of an aerobic activity. The post-stretching rest times were consistent with the findings of Hardy, who found the effects of PNF stretching techniques could last as long as 6 minutes. This was critically important to ensure that the effects of CRAC method were not lost. Statistical analysis. An interclass correlation coefficient, ICC, was used to assess the consistency of all 3 dependent measures over 3 trials. Interclass correlation coefficients were calculated on all pre-scores. A 2x3 repeated measure and analysis of variance was used to assess for differences between conditions over the pre and post. The measure command of SPSSS, Chicago, Illinois, USA, was used to enter each measure of stability, overall, medial, and lateral, ML, and AP, into the model. Follow-up tests, contrasts were completed. If necessary, alpha was set at 0.05. Results. Reliability coefficients indicated that the dependent measures were reliable over 3 trials. The ICC for overall stability was 0.88, 95% CI, 0.83 through 0.91. ML stability is 0.90, 95% CI, 0.87 through 0.93. AP stability, 0.83, 95% CI, 0.76 through 0.88. There was no interaction for either the overall stability, P is 0.48, and AP stability indices, P is 0.95. The omnibus test for ML stability indicated a time/condition interaction F equals 3.96 under 258, P equals 0.024, power equals 0.69. Descriptives are presented in Table 1. Follow-up contrasts on simple effects within the condition indicated that there were no differences between conditions pre-testing for ML stability. P equals 0.238. There was a difference between WS and con. P equals 0.037, power 0.57, and SO and con. P equals 0.041, power equals 0.51. Post-testing WS 1.84 plus or minus 0.81, and SO 1.95 plus or minus 0.83. ML stability scores were better than control, 2.40 plus or minus 1.69 at post-testing figure 1. There was no difference between WS and SO post-test. P equals 0.47. Discussion. The purpose of this study was to examine the effects of the CRAC form on PNF stretching on postural stability, identified as balanced using measures of both ML and AP stability, and to identify quantifiable differences in these measures with the inclusion of a brief warm-up. We found that ML stability was significantly improved in the combined WS and SO conditions compared to in the control condition, even though there was no statistical difference between the two stretch conditions. The WS condition had a lower, better ML stability score. The improvement in ML stability may be because of A, the actual warm-up, B, neurological facilitation from the contract relaxed portion, and C, irradiation overflow from the antagonist contract phase. Obviously, making generalizations to the overpopulation is tenuous because we had a small sample size, did not have independent groups, and our sample was of a specific healthy population. However, our study does begin to examine the effects of warm-up combined with PNF, CRAC stretching, and the use of CRAC methods on stretching. Performing a warm-up consisting of low-intensity rhythmic limbering exercises is known to increase core temperature, facilitate blood flow to muscles, and enhance neuromuscular activity, and may serve to promote efficiency in performance measures. These low-level contractions can increase muscle excitation and may last up to 30 minutes. Accordingly, it is not atypical to expect better scores in ML stability with the inclusion of a warm-up. However, in light conflicting results between studies and the fact that CRAC PNF improved balance scores, other physiological factors may have contributed to the improvement in ML stability. Young and Elliott argued that contract relaxed methods produce a neurological facilitation mechanism that may result in lingering activity of motor units. They found that the PNF contract relax stretch treatment had no significant effect on concentric performance and power performance. It was argued that these changes may be because of autogenic inhibition from spindle secondaries, type 2 afferents, and autogenic facilitation through spindle primaries, 1 alpha afferents. Although discharge from spindle primaries is enhanced after contraction, it is negated after a brief stretch. However, if the stretch is an active stretch, as in the CRAC protocol used in this study, the active stretching procedure may promote agonist firing because of the deceleration of antagonist activity. Accordingly, the agonist may continue to exhibit type 1A and 2 afferent stimulation because of the maintenance of alpha motor neuron and consequently gamma motor neuron excitability, and therefore maintain some degree of motor neuron excitability. This argument is supported by current knowledge of stretching physiology and the activation sequence of alpha and gamma motor neurons. Whenever skeletal muscle fibers contract, the firing alpha motor neurons cause a concomitant firing of gamma motor neurons because of the connection between the intrafusal and extrafusal fibers. The firing of gamma motor neurons causes the end in intrafusal fibers to contract, thus maintaining the stretch in intrafusal region and preserving the ability of the sensor endings to detect stretch and respond to muscle stiffness. Another mechanism may help explain the improvements in ML stability balance measures is Irradiation overflow. Originally described by Knott and Voss, this involved the spreading and increased strength in response can either be excitatory or inhibitory. Irradiation overflow may be because of movement synergies and post-activation potentiation, PAP. Post-activation potentiation is discussed by Behm and et al. May be defined as an improvement in force production capability after a voluntary contraction. Post-activation potentiation is known to produce increased cross-bridge formation in muscles in the presence of reduced calcium activity. Activation. Low levels of calcium may be present in the agonist muscle during the antagonist phase. Post-activation potentiation may help to maintain activation of type 1A and 2 afferents and promote co-contraction of the agonist and concomitant overflow of the stimulus to other nearby muscles. This can facilitate muscle stiffness that may in turn help to improve ML stability measures. This hypothesis is supported by other investigators who have demonstrated increased EMG activity with active stretching and increased facilitation of intrafetal fibers during active movements. Etner and Behm conducted a study that used the CRAC method and reported a depressed H reflex. This would indicate that there was a depression of motor neuron pool excitability during the CRAC protocol and suggest that CRAC methods will result in reduced muscle stiffness similar to those reported by static stretching. However, the CRAC protocol used in our investigation was different from the one used by Etner and colleagues. We employed an active stretch for the antagonist contraction phase to assume the new ROM, as opposed to the passive stretch used in the protocol. The passive stretch used in their protocol for the antagonist portion possibly produced neurological changes similar to a passive static stretch. These changes causes a reduction in motor neuron pool excitability and may also result in the increased tendon slack, both of which are not favorable for force production requirements and to maintain ML stability, balance, and performance measures. Type 1B afferents, GTOs, transmits information to the same interneurons as primary and secondary afferents and descending pathways. A static passive stretch may result in decreased H reflex activity, not only because of the GTO activity, but also because of the synergistic of afferent input and volitional modulation from higher centers. It is possible that an active stretch which promotes irradiation, facilitation of intrafusal afferents, will depend more on reflexive activity and excitatory response from higher centers, and not cause a depression of the H reflex. This is supported by studies that related to EMG activity during static, passive, and varying PNF stretchings. Therefore, passive static stretching in addition to PNF techniques that use passive methods may negatively impact ML stability / balance because of decreased alpha and gamma motor unit activity, increased tendon slack, increased type 1B fiber activity, and possibly afferent proprioceptive transmission via dorsal columns in the spinal cord to higher centers. Regarding the AP measures, we found that scores were maintained regardless of condition. We hypothesize that this may be because of the learning effect discussed by Tarantola et al., who found that human stance stability improves with repetition of a task. However, the more interesting point here is the fact that PNF CRAC protocol did not result in a reduction of any scores and is a different outcome to the findings of Behm et al. Regarding the effect of static stretching on balance. Practical applications. The most significant finding in our study was the improvement of ML stability and raises important questions regarding application. Adequate balance postural stability measures, ML and AP stability, are thought to help decrease the risk of certain injuries and maintain adequate posture needed for sports performance. Other investigators have suggested that pre-activity static stretching will decrease performance measures. Further, evidence suggests that some PNF methods produce muscle tendon changes similar to that of static stretching. These muscle tendon changes may reduce performance measures such as vertical jump, balance, reaction time, and speed. However, the research also shows that CRAC PNF methods may produce different responses in muscles that may facilitate muscle contraction and therefore maintain motor neuron excitability. Additionally, most articles presenting research findings regarding pre-activity stretching have used protocols that are unrealistically related to the nature of sports and fitness. For example, in some studies, stretches were held in excess of 20 seconds. However, in true sporting and fitness pre-activity stretches preparatory stretches may be held for less than 20 seconds. Moreover, a warm-up is also included in real-life pre-sporting and fitness events. Therefore, the additive effects of these activities and stretching may not negatively impact performance measures. Further study is needed on the effects of various stretching techniques on all performance measures that duplicate real-life pre-activity practices. At the current time, we neither endorse nor discourage the use of pre-activity stretching without warm-up. However, we encourage both clinicians and fitness professionals to use the available evidence wisely, and if deciding to use pre-activity stretching, to A. consider a warm-up, and B. consider CRAC PNF methods using an active stretch for the antagonist portion of the motion or the movement. Acknowledgements. Conflict of interest statements. Financial support has not been received by the corresponding authors or any co-author of the study. The study was approved by the Institutional Review Board of the Florida International University, Miami, Florida.